to cover 4 massive topics. So I'm just going to go right ahead. Okay, so this is taken from your matrix, which has been revised from our matrix. So obviously can't cover everything today, but definitely we'll try to cover most things. All right, and the things that aren't covered will either be covered in the very end of the buzzwords or will be covered by Lauren later today. So the first thing is meningitis and encephalitis. So obviously we know that meningitis is inflammation of our meninges, so the meninges surrounding the brain and spinal cord, whereas encephalitis is inflammation surrounding within the actual brain parenchyma. So it's important to distinguish these two because they have different causative organisms and different treatments, and they present very differently. So some of the risk factors in children particularly include very young children, unvaccinated children, so those not vaccinated to Hib, recurrent or even current infection, for example, otitis media may make its way to the meninges. Asplenia, because we know that if you don't have a spleen, you're more likely at risk of infections for like the encapsulated organisms. If you're immunocompromised, head trauma, if you've had sick contacts, and if you have cranial abnormalities. So in terms of history, we obviously ask fever, immunizations history, plus minus seizures. So this is in particular for meningitis. Infants don't present the same way that adults do, with the whole triad of headache, photophobia, fever, neck stiffness. So essentially they present with these non-specific symptoms like irritability, lethargy, poor feeding, and they become sometimes really floppy. So you always have to be thinking meningitis. And obviously one of the red flags is the non-blanching purpuric rash, which of course tells us it could be a meningococcal meningitis. And when we're thinking encephalitis, that's our altered consciousness. So usually you ask mum or dad, you know, has their behavior been different? Have they had a personality changed? Have they been seizing? Because that's more indicative of encephalitis. When we think about what causes it, so meningitis is mainly caused by a viral organism, so that being EBV, enteroviruses, or varicella zoster virus. However, when it is microbial, it depends on how old the child is. So if the child is 0 to 2 months, it tends to be either E. coli, listeria, or group B strep. Greater than 2 months, we see the strep pneumoniae, Neisseria meningitidis, and Hib, particularly those that are unvaccinated. And then if we get a skull fracture, regardless of age, you get those commensal organisms that are typically on the skin that then opportunistically infect the meninges. So that's your Staph aureus and Staph epididymis. Your encephalitis is typically caused by herpes simplex virus, but it can also be caused by other things. So before we go into treatment, obviously examination is very important. So with anything, you begin with vital signs. So you'll be looking for a fever or hypothermia, tachycardia or hypotensive or hypertension, which could indicate shock. Obviously in infants, their anterior fontanelle isn't yet fused. So sometimes because of the inflammation, you'll actually see those bulging fontanelles. And so next to the red flag is literally the red flags according to the Royal Children's Hospital. So the other things are high-pitched cry, which can also sometimes indicate the start or even a seizure episode. Neck stiffness, which can be absent in babies. Focal neurological signs, and that purpuric rash that we talked about before. And in terms of doing some signs, so Koenig and Brudzinski, so Koenig being having their legs flexed and trying to lower them, which you either get resistance or it's quite painful. And Brudzinski is when they have their legs flexed and you try to push their head up. So all of these are signs of meningitis and will be positive. In terms of investigations, Michaela covered this before with the fever of unknown origin and what to do, but essentially it's a little bit similar. So at the bedside, you want to do blood sugar levels, especially if you're doing the lumbar puncture, because those two can help tell you the diagnosis as well. In terms of the blood cultures, yes, so you want to do the blood cultures, 3 blood cultures from different areas, FBE, UEC, CRP, which would be increased, and meningococcal PCR. There are certain circumstances where you don't go straight to the lumbar puncture. You can do neuroimaging if there are signs of increased intracranial pressure, or if you're uncertain of the diagnosis, like if there's a mass effect or etc. And FNS is focal neurological signs. I think I've unabbreviated it in the notes because I was trying to make it look neat. And then the special test, lumbar puncture, which you can look at your cerebral spinal fluid. And this is really important because this tells you, is it bacterial or is it viral? Because like we said before, that's really important. And as we know from 3rd year, so bacteria tends to present in the way, I don't know if this is true, but I think bacteria eats all the glucose. So they have low glucose, they tend to have more neutrophils and not as many monocytes, whereas a viral picture tends to give you either normal glucose, low neutrophils and high monocytes. And you can also do an EEG, in particular with encephalitis. So in terms of the management, also I should say I can't see the chat, but I'm sure Ash and the other girls will answer any questions. So obviously, as per the RCH guidelines, don't delay antibiotics. So if you have a clinical suspicion that someone has meningitis or encephalitis, don't delay antibiotics or antivirals greater than 30 minutes after you've made that decision. So the first thing you want to do is you want to admit the child, call the pediatrics team, obviously make sure that they're stable, so doctors ABC, gain IV access, and give antibiotics, and I should say antivirals within that 30 minutes. Your empirical therapy is, if it's meningitis, less than 2 months, you want to cover your E. coli, your Listeria, so you're using benpen and cefotaxime IV. We talked about that before as well, that you can't use ceftriaxone in children less than 2 months. So then after 2 months, you will just opt for IV cef. If you're suspicious of encephalitis or the child is immune compromised, then you also want to add on acyclovir IV as well. Steroids, less than 2 months, it's not advised because I suspect that there are some, wait, can you still hear me, guys?
Yeah.
Yeah, cool.
Went louder.
My headphones died, excellent. So yeah, less than 2 months, not advised because there are some effects on neurodevelopment, whereas greater than 2 months, you actually tend to provide them together because it reduces the risk of hearing loss that can be a complication of meningitis. And typically, I'm sure you may have seen it at the hospital where they like to give it either together because you need to give it within 12 hours of those antibiotics. And for ongoing management, obviously, monitor them continuously, repeat bloods, treat the seizures by the seizure protocol, which we'll go through later in neuro. Isolate, so within the first 24 hours, you isolate, and some cases are reportable, like the Neisseria meningitidis and Hib are reportable to the Department of Health. So these are some complications. I won't read them out to you, but essentially, just note that hearing impairment is one of them, and it's a major risk factor for like the cranial nerve involvement. So that's why they say that there should be a admission appointment to do an auditory assessment, as well as a neurodevelopment progress to see if it's affected anything long term. But yeah, that is that. So immunizations, for our year level, it wasn't a green condition, but for you guys, it's a green condition. So I apologize if there's a bit of an overlap with GP, but I assume that this is because they're potentially thinking about making it a OSCE station where you explain why you want to give the immunization, etc. So you just be explaining to mum or dad a vaccine contains non-harmful copies of the bug that children commonly become infected with, and it's modified enough so that it doesn't actually cause the illness, but the body can get ready on how to respond to it. And as long as you use the word priming the immune system, then I think you'll get that mark. So in terms of before vaccination, obviously ask them, have they had any recent illnesses? What are they, have their vaccinations been up to date? And their past history and how they've previously reacted to vaccines. So have they had an allergic reaction before? do they have lowered immunity? So in cases of cancer, HIV, AIDS, or leukemia, where they're immune suppressed, it is a contraindication to give them vaccination, so you would not give. You discuss a little bit about the developmental history, grab their green book, and you normally just have to sign off on the vaccinations. And obviously you'd go according to the schedule, and if they're greater than 6 months, you consider giving them influenza, but the schedule is on the next slide. So after the vaccination, you keep them for 15 minutes in the clinic. Little local ADRs may occur, but then you also tell them that because the rotavirus, given that 2 and 4 months is a live attenuated virus, it has a risk of causing intussusception. So maybe just a little spiel on if you notice any bloody diarrhea or any bloating or any masses in the abdomen, just go to the emergency department or come back. And then just advise fluids and just a little bit of paracetamol should be fine. Contraindications, they like to ask on your GP end of year exams in 4C. So I just thought, why not? 2 birds, 1 stone. So severe allergic reactions from a prior dose. So as long as these are anaphylactic reactions, then it's a contraindication. If you currently have a severe acute illness, it's a contraindication for the current vaccine, but then you just wait till the child improves and then you would rebook them for their vaccination. If they have immunodeficiency, they can't, or even if they're pregnant, they can't have live vaccines. So as you may already know, MMR is contraindicated in pregnancy for that reason, varicella and rotavirus as well. And some relative contraindications is if they're febrile greater than 38.5 and if they have an evolving neuro illness, but an egg allergy is not a contraindication, which was one of the past exams. So I don't know how to teach you this in any way that's going to make it fun. I don't think it's possible. So let's just, I don't know. So at birth, hepatitis B is given in the hospital with vitamin K. And then at 2 and 4 months, that's where you get your rotavirus. And then you have this Infectix hexa, which is like the 6 vaccinations in one. Notice at 12 months, they have the meningitis ACWY, but there's no B. Because B isn't on the schedule, but you can still get it as an extra vaccine. So some extra vaccines you can get that's not on the schedule is obviously influenza, that's recommended every year. So you can start giving influenza after 6 months. Children less than 9, for their first dose, they have to have 2 doses 4 weeks apart. And after that, just 1 dose like normal. TB can be given to people who are high risk or traveling to an endemic country. Like usually they'll use my country, which is Bosnia. So whenever you see Bosnia, they're trying to like hint TB, just really annoying, but that's fine. So meningococcal B, again, out-of-pocket costs. Okay. Kawasaki disease was actually really well covered by Christian. So he covered everything I wanted to say. He even used the same acronym as me. So I'll just let you guys read over it. Everything's there. The only thing is like the echo, you want to do at baseline and 6 weeks after. You're looking for coronary artery dilation, and he said pretty much everything else. And so now we're going on to viral exanthems. So exanthem just meaning a widespread erythematous rash that's accompanied by systemic symptoms like a fever, a headache, malaise, most commonly associated with a viral infection. So in this circumstance, they're all going to be viral exanthems. And these are the most common ones you have to know. You can probably snooze on the last one because it's a bit more GP, but it's still technically a viral exanthem. All right. So measles, caused by morbillivirus. They like to test you on measles. So incubation period is 10 to 14 days. And it typically presents with 5 Cs. So you have your conjunctivitis, which is non-purulent, cough, coryza, and your pathognomonic cochlear spots, which are these blue-red lesion, usually next to your molars within your buccal mucosa. So that's, if you're going to remember anything, just remember that cochlear spot, measles. And also the rash is cephalocaudal, so it starts from behind the ears and then spreads down into the, to the body. So last year we had the question, how long is measles infective for? So
4 days before, 4 days after the rash. So just to remember, 4 days after the rash is when they stop being infective or contagious. There are certain complications that can happen, and the diagnosis is clinical. Maybe you can consider doing serology, and the treatment is mainly supportive. Isolation from childcare until 4 days after the rash. 4 days after the rash. Okay. Prophylactic vaccinations for people who've come into contact. And studies have found that vitamin A helps to reduce the risk of the subacute sclerosing panencephalitis, as well as some of the other complications, as well as obviously antibiotics. And this is a notifiable illness. So you notify the health department. And this is just what the rash looks like. And these are the Koplik spots. Okay. They did this strange thing where they started listing like conditions based on like 5th disease, 6th disease, and they started counting until they realized there's so many conditions. So it's kind of still there, but phasing out. So this condition we call roseola infantum. And typically because of the group, it tends to affect. So it's like a light pink rash affecting like infants. It's caused by mainly human herpes virus number 6, but also can be number 7. Mainly children aged from 6 months to 3 years old are affected. And there's this prodromal period. So they normally have this like coryza, high fever. So that's really important. And occipital lymph nodes plus minus. Once that fever ends, so the child starts getting better, you start going, oh, thank God. And then all of a sudden your rash spreads. So fever ends, rash descends is the buzzword for this condition. And typically you get those pinpoint rose pink lesions. It kind of looks like measles, but like a little bit lighter. So here's a photo of that. And typically it will just resolve on its own. It's a clinical diagnosis. You really don't have to do anything. But the issue is that because of the high fevers you get in that prodromal period, it's has a high risk of getting febrile convulsions. So 5 to 15% of children will end up having a febrile convulsion, which is also mainly benign, which we'll go through later. So again, it's a self-limiting illness. If you get it in an OSCE, so you just want to reassure the parents, 95% of children are infected by 2 years old. It normally resolves within 7 days. Just isolate them from childcare and just supportive. If I don't say what it is, it's just hydration and paracetamol in these cases. But the paracetamol, as we talk about later, doesn't actually reduce the fever. It just helps the child feel a little bit better. So that is the controversial point we'll be discussing in febrile convulsions. So erythema infectosum, I think the cheeks are infected, like they're red, also known as slap-cheeked, also known as 5th disease, caused by parvovirus B19. So we're just thinking, that the parvovirus B19 part we don't have to remember, but actually we do, because sometimes they won't ask you what is this condition. They'll say what is the pathogen that causes this condition. And the buzzword is anemia of the newborn. It affects early school-aged children, and it also has this prodromal period of like an urti, a fever for about a week, and then you break up into this rash that's mainly like on the cheeks. And then the other buzzword is that then you have this reticular lace-like rash on your trunk, your face, and your extensors. Mainly a clinical diagnosis, very easy to identify on a question, because it'll say something like mild fever, and then they have these infected cheeks. The thing is though, parvovirus B19 affects reticulocytes. So if a child already has like an underlying hematological condition where their red blood cells are already affected, then it can lead to an aplastic crisis. And that's also why it causes anemia of the newborn. But that's more of a women's buzzword. But yeah, you want to isolate them from childcare and supportive therapy. Okay, hand, foot, and mouth disease. It's caused by a family of enteroviruses, most commonly Kawasaki A16 virus. And as you would have guessed, blisters on the hands, feet, and mouth. Typically in 3 to 4 years old, in summer and autumn. It's very rare to have this in adults. But that's also because a lot of people have it during childhood, so it doesn't really tend to happen in adulthood. So you have this prodromal period of a fever and a sore throat before breaking out into this rash on your hands and your feet. And you can have these vesicular mouth lesions, which means that sometimes children don't want to eat and they can end up losing weight, and that can be the reason they present, and then you realize they have hand, foot, mouth disease. When it's solely in the mouth that it's affecting, it's called hepangia. Again, clinical diagnosis can consider serology and just the same things as usual. So obviously hands, foot and mouth has all these lesions. It'll be quite obvious in the exam question. Okay, so in terms of chickenpox, you already know it, varicella zoster vaccine. Yeah. Just very conscious of the time. Oh, good. Okay, so the thing with this one is 10 to 21 days incubation period. You start off with these like peritic, like really itchy papules that then turn into vesicles, which are just fluid-filled lesions that then become crusted. With this one, obviously again a clinical diagnosis, but it's contagious during that time until all blisters have scabbed over. Again, supportive. You can sometimes, if they're immunosuppressed, prescribe acyclovir. And in pregnancy, let's say a pregnant lady comes in, she's had contact with someone. According to Monash prompt, you give her the zoster immunoglobulin, which you can also give to neonates as well. So rubella, which is not as important, I'm just going to skip it over. You can read over it. So prevention, MMR, don't give it during pregnancy. It's a live vaccine. Over 16 weeks, you can reassure, but less than 16 weeks, you want to do termination of pregnancy. Mumps, the only thing you have to know about mumps is swollen glands. That's literally it. So they'll just say something, swollen glands, mumps. Pityriasis rosea, that's a GP condition, self-limiting condition where the person has had this ERT. A lot of them actually don't have any prodromal symptoms except they're really itchy, and then they get this like herald patch, which is like this salmon scaly patch, usually on their trunk, and it appears before the generalized rash, and they call it the collarette sign because it's like red on the outside and has a central clearing, and then because it follows the contour of the skin lines, it looks like a Christmas tree or a fir tree. It goes away on its own, nothing to worry about. Okay, so this is what it kind of looks like. Sorry to rush, but essentially red rash on the cheeks, low-grade fever. So we're not thinking Rosella infantum because that's a high-grade fever, so we rule it out. On the cheeks, it's quite obvious. Okay, sorry if I'm going really fast. So essentially the next topic, which is a green condition, is eczema, which is atopic dermatitis, also known as. So chronic itchy inflammatory skin disease, very common in children, and it's caused by many different things, also associated with atopy. So obviously in the exam you ask all those questions. Affects 30% of children. Usually it starts before they're 12 months of age, and the earlier the child gets it, the earlier you can treat it and the earlier they grow out of it. Very few children end up having lifelong eczema, and the clinical presentation actually varies according to age, which I find quite interesting. So if the child is a infant, obviously all of these are 10 out of 10 itchy, dry lesions associated with atopy. We already know that from GP. Infants tend to be widely distributed, dry, scaly rash, usually with scratch marks. Cheeks are actually the first place to be infected in infants. And the napkin area, the napkin area is usually spared because of the moisture of the nappies. In terms of toddlers and preschools, for some reason they get it on extensor surfaces, whereas we know in adults it's normally a flexural condition. So that's just to show you the extensor surfaces, and then it becomes flexural later on. And then these are some of the guidelines in diagnosing it. Investigation, obviously, clinical diagnosis, but if you were suspicious of a superimposed bacterial or viral infection, you can swab and look for some red flags like poor growth, persistent diarrhea, recurrent infections. So is there something else going on? And we'll go over some of the superimposed infections next. Lifestyle, just a little acronym. So avoiding irritants, bathing once a day in lukewarm water. If you have a bath no longer than 5 minutes, don't use any soap. Clothing, cotton, loose clothing. Damage prevention. To prevent those excoriation marks, cut the baby's nails really short, and then at night just have little mittens so they can't scratch themselves. Educate the parents as well, of course, always important, and just like daily emollients and moisturizers. If there's a flare of eczema, then you're going to go from twice a day to 4 times a day. If it's really itchy, you can add on like a steroid topical treatment. And if it becomes really scaly, you can add on a tar ointment as well. A tar gel, sorry. And then you can apply moisturizer on top of the steroids. And sometimes they do bleach baths, which just helps to reduce the bacterial load as well. So that is good. Impetigo is a superimposed bacterial infection. So the buzz is your honey-colored crusted erosions caused by Staph aureus. Normally just a bacterial swab, you don't need to biopsy it. Essentially you just clean the wounds, antiseptic, wash. You consider Fluclox oral if it's severe. So you don't go straight to Fluclox like I used to think in GP. You actually do these other things and then you consider Fluclox. But that's what it looks like. So it'd be like honey crusted comey lesions. This is the other one that they love more so in GP, where it's like blisterly, like erosions in the skin. And this is actually caused by herpes simplex virus 1 or 2. And this is when you consider oral acyclovir. This is one of the few medical emergencies in Derm. It doesn't have to be IV acyclovir like I used to think from GP. It can also be oral. Infantile seborrheic dermatitis is essentially caused by a yeast that overgrows on the skin and produces these fatty acids that then cause inflammation. And the buzzword there is cradle cap, and you basically just have to do regular washes. They'll maybe give you a photo like this, and that's all you have to remember. Scabies, intensely itchy rash caused by a parasitic mite. It like burrows into your skin. So you can see it here. It travels in through, like it enters here and then goes all the way through and burrows in under your skin. So I feel itchy just talking about it. So it's an intensely itchy rash. You always look in between the finger webs there because that's typically where they tend to go. It happens in school-age children because they like to hold hands with each other. They like around each other quite a lot. So it's spread by skin-to-skin contact. And sometimes if you use the magnifying dermatoscope, you can actually see the mites, the eggs, or even their feces on the skin. But essentially you just treat anyone who's come in contact with the child and then treat again 1 week later. And then go back to school 24 hours after you've had the first treatment. It can either be a cream, which you apply to the whole body and leave it for 8 hours on your body and then repeat a week later. Or you can consider an oral medication. But no, this happens in poverty and this medication can be expensive. So just some things to think about for real life. This has become a green condition for you guys, which confuses me, but that's fine. So this is herpes stomatitis, so HSV gingivostomatitis, which is a self-limiting inflammation of your mucous membranes in the mouth, so including your lips, your tongue, your hard palate. And it's when you have a primary herpes simplex virus. So HSV1 affects typically younger children. Almost everyone, so 99% of people will be infected by 5 years old. And then HSV2, I should write 2 there, occurs after puberty when people start doing other stuff. Not for today, that's fine. So clinical presentation, they can have a prodrome, lesions arise with the oral cavity, and if you're not careful, it can lead to encephalitis. So obviously, you'll see these vesicular, which are fluid-filled lesions inside the mouth. They have this red halo around them. And obviously, with all infections, you can get lymphadenopathy. That would be painful. Investigation, clinical, or you can swab it for PCR. Serology is really helpful in this instance. Management, mainly supportive. So obviously, it's inside the mouth. It can be painful. So the main thing is obviously pain relief and analgesia. So paracetamol, ibuprofen, limited ibuprofen, and a lignocaine 2% gel that you just put inside the mouth. If they're admitted to the hospital because of their pain, you can give them opiates as well. Hydration, that's just oral hydration solution. Antivirals, you can consider acyclovir and consider school excursion. There's a few things listed on RCH, so I haven't got it there. Sorry guys, I'm talking really fast. Okay, febrile convulsions. So this is like the big one you have to remember. So this is also likely to be oscubal. So this is convulsions in a child aged between 6 months to 6 years old in the setting of acute febrile illness. And that acute febrile illness can be anything from a UTI to an ERT to gastro to anything, otitis media, anything. Without these factors here. So essentially, it's a very common condition. This is everything you're going to tell the parents and the management as well. It occurs in 3% of children. 33% tend to recur. So something about threes is happening here, I'm not sure. The younger you get it, the more likely it is to recur. So if they get a febrile convulsion when they're less than 1 year old, they have a 50% chance of having it again. But then their propensity towards getting febrile convulsions decreases significantly after 6 years old. And it does not increase the risk of epilepsy. The risk of epilepsy is still 1%, just like the rest of the population, unless they have a family history, an atypical febrile convulsion, or neurodevelopmental problems separate to this episode of febrile convulsion that they're having at the moment. There are different subtypes. So there's simple. Most of them tend to be simple. So this is where they have the generalized tonic-clonic, generally lasts less than 15 minutes and doesn't occur again in the same illness. So just to make that very clear, so let's say the child has a viral ERT now, and they have a febrile convulsion. It is unlikely to occur again in that illness, but it is likely to recur. So 1 in 3 chance of it recurring in another illness. Complex is when they have focal features, it lasts for greater than 15 minutes, it can reoccur in the same illness, or it's incomplete recovery within 1 hour. And then febrile status epilepticus it has a different definition as well, but it can be when you're having a seizure for greater than 30 minutes. And febrile convulsion, which if they did that to you, that would be really rude because it's no fever. They can just have a gastro or viral ERT, and that can lead to a febrile convulsion in the absence of a fever. Okay, so investigation, really you don't have to do anything. If they're less than 3 months, and Michaela alluded to this before in her slides as well, do a full septic workup. Less than 6 months, you consider a central nervous system infection, and less than 12 months, if they're not immunized, then you consider a lumbar puncture. Otherwise, no need to do any investigations. Management, we kind of talked about the reassurance before. Give them a pamphlet, and obviously active seizure management. Tell the parent to stay calm, place the child on a soft surface on the side, don't put anything into their mouth, don't put them into the shower to lower their temperature. And if they're still seizing at 5 minutes, call the ambulance. Fever control, just reiterate to them that paracetamol and cool baths have not been shown to reduce febrile convulsions, but they do make your child feel more comfortable. So you can give it for that purpose, but it's not used for fever control, besides paracetamol being an antipyretic. We won't discuss that today. Okay, epilepsy. Guys, I'm so sorry. 8 minutes. Okay, what is a seizure? So I'm sure you already know, clinical expression of abnormal excessive synchronous discharges of neuron, primarily in the cerebral cortex. Separate to that, epilepsy has distinct criteria. So it's either one of the following. The first one you already probably know from 3B, greater than 2 unprovoked seizures 24 hours apart. So it's not the same seizure. Or 1 unprovoked seizure, and the probability of a future seizure similar to the general occurrence risk that you get with the first dot point over the next 10 years, or a diagnosis of an epileptic syndrome, which we'll go through later. So as you know, seizures can either be focal or generalized. Focal, where the person is has impaired consciousness, or they're aware, so one of the two. Can be motor or non-motor, or generalized, where they tend to have impaired consciousness. And so those are where the buzzes are. So generalized seizures, so absent seizures. Absent seizure is a non-motor seizure. Sorry, I should really point that out. Okay, so this is the outlier. Okay, so an absent seizure is, I'm sure you've heard it, short periods of blanking out or daydreaming for 10 seconds. They stare out. They can have lip smacking or hand flapping, and they're completely unaware of the event. In ED, you can ask them to breathe into a bag because hyperventilation tends to trigger this type of seizure. And one of the buzzwords is on EEG, you can have a 3 Hertz spike wave. And you'll see later on, depending on if it's like simple or generalized, you have different medications. But if it's absent seizures, you tend to go with ethosuximide first. That's first line. All right, tonic is when the tone is increased. It tends to be bilateral and induces cyanosis. And they'll have this cry, that seizure cry. They can be quite confused. It lasts for about 20 seconds and it occurs overnight. So some of the syndromes you see this in is in West syndrome and Lennox-Gastaut syndrome. So those are the buzzes on the next page. Myotonic is that brief bilateral jerking, occurs in clusters, and that's the juvenile myoclonic epilepsy. And atonic, I don't know what, this is my favorite one. They just like fall. So sudden loss of tonicity, drops to the ground. I mean, that would be awful, but it's like in an exam question, it is easy to identify. And tonic-clonic, which is what we know to be, or what the general public knows to be a seizure. So this is the tonic phase and the clonic phase, where you have the tongue biting, the eyes fluttering, that post-ictal phase, loss of consciousness, multiple triggers. There's also a syndrome called photosensitivity that I don't cover in the others. So it's just induced by flashing lights. Okay, buzzity buzz. Okay, juvenile myoclonic epilepsy is the throwing plate syndrome. So this is the most common generalized epilepsy. It's very common in adolescent males. So I think adolescent male gets up in the morning, goes to grab a plate and then drops it because they have a seizure. They have like a bilateral jerk. Occurs in the morning post-sleep deprivation. EEG shows anterior spikes. And because it's generalized, we give sodium valproate, but there's the management on the next page. We have Lennox-Gastaut syndrome. So this commonly affects very young children, has very poor prognosis. So I think 85% of them have intellectual disability. So it's actually one of the sad syndromes. But what happens is they have a drop attack. So in the question, it'll say something and it'll say they just suddenly fell. So they have to have this quite long term. So some of the others, if they're seizure free for 2 years, they can slowly wean off the medication, but they really can't for this syndrome. West syndrome is infantile spasm. I think infantile spasm sounds very benign, but it's actually not. Occurs in infancy, so 4 to 6 months it starts occurring. So they have these like recurring seizures over a few minutes and like these Salem spasms and drawing up of the legs. And sometimes they have this flicking out of the arms like wings. So that's one of the buzzwords. Again, poor prognosis. It can even progress to Lennox-Gastaut syndrome. And for this one, you give them prednisolone 10 milligrams orally. So this is supposed to, I think, help reduce how frequently the seizures occur, but there's really not much you can do for these babies. Temporal lobe epilepsy is focal. Obviously, you have very like precise symptoms like aura, like olfactory things, deja vu, change in taste. Dravet syndrome is intractable seizures, and Rolantic epilepsy is a benign childhood epilepsy. Most people grow out of it. It happens at night where the face twitches. They have this like torsion of the face or sensation in the arm goes weird, like during the night while they're sleeping. But many children grow out of it and it has a good prognosis. So this is one of the slides I stole from Ash. So focal, carbamazepine, generalized valproate, absence, ethosuximide. So there's a first line. There's also second line. And there's some adverse side effects you guys can read in your own time. Don't forget about breath holding attacks like blue spells, like or reflex anoxic seizures. So those are the other two to remember as well. Okay. I'm very conscious of time. Ash?
You've got 3 minutes.
That is simply not a thing that's going to happen.
Wait, I'm just double checking.
I still have so much to go. Damn.
That's fine. Go for 10 minutes.
Okay. Okay. I'm just going to have to, so the past exams, just do it yourself. That's fine. All right. Status epilepticus, single epileptic seizure that is greater than 5 minutes, or 2 seizures between the 5-minute period without returning to normal in between. This is a medical emergency, and in exams, they like to ask you, how would you treat this? So essentially, you want to continuously monitor their airway, support their ABCs, check and monitor their blood sugar levels. If they're high risk, you commence active treatment. If they're low risk and the seizures spontaneously resolved, then you just monitor them. But if it's still continuing, then you commence active treatment. So you begin by using the first line, which is a benzo, midazolam or diazepam. Both are fine, but please account for the benzos given pre-hospital as well. Repeat again if it's ongoing after 5 minutes. And then after that, you can give IV phenytoin over, I believe phenytoin is actually 5 minutes and the others are 20 minutes. Or maybe they're both 20 minutes, yeah. Okay, you can give those over 20 minutes. And then if not, you can seek help as well. So this is kind of the pathway for your status epilepticus. Past exam questions. So we're going into Haem Onc land now. So 13-month-old girl is being investigated for so pale and poor feeding. HB electrophoresis is normal. So that's important because they're trying to tell you there is no beta thalassemia. Which is an option there, so we can rule that out. There's microcytic anemia, white blood cells are normal, and platelets are normal. So microcytic anemia, tails, you ruled out thalassemia. Oh, that's my thing. Okay, so it's iron deficiency anemia until proven otherwise. So most common cause of anemia in children, normally in infants, the biggest risk factor in those less than 12 months old is excessive cow's milk because the iron in that is quite low and it's not the same iron that you get from food. So it's not as readily absorbed. In children, the questions might say IBD, celiac, or even surgery that can lead to IDA. Adolescents, all the above plus menorrhagia. The clinical presentation is the same essentially. I guess you get more non-specific symptoms like behavioral disturbances, we went over that before, and lifestyle mainstay of treatment, decreased cow's milk protein. So less than 12 months, no cow's milk. Greater than 12 months, limit to 500 milligrams a day. Consider dietitian referral. And supplement them with ferrous sulfate. Just like in adults, you promote vitamins. So vitamin C helps you better absorb iron. So obviously you promote that with orange juice, or you give them vitamin C supplementation as well. You retest, usually after 3 months, and rarely you need a transfusion. I'm sorry, I'm going so fast, apologize. Okay, a pale looking 2-year-old with widespread petechiae and cervical lymphadenopathy. This can be many things, and that's why they've kept some things out of the question. But when you see a pale 2-year-old, so obviously low HB, low platelets, and high white cells, that just screams to me a bone marrow issue. So acute lymphoblastic leukemia, so ALL is the most common malignancy in children. Presents typically in between those 2 to 5 years old. Typically B-cell lymphoblastic leukemia. And what happens is you get the progenitors that proliferate. It's associated with Down syndrome, which is one of the buzzwords. And if you can think about exactly what's happening, so you have the systemic features, of course, but if you think about the pancytopenia, so this tumor is occurring in the bone marrow, so you can have anemia symptoms. White cells means you can have recurrent infections, because even though you have a lot of white cells, they're immature, so they're not doing the roles that they would normally do. Platelets, so you don't have platelets to stop your bleeding, so you have mucosal bleeding, spontaneous bleeding, petechiae, bruising, and then if these cells go and met or infiltrate the spleen or liver, you can get LFT derangements. Lymph nodes, you can get lymphadenopathy. Bone marrow leads to bone pain. We try to stop central nervous system infiltration before it happens. So these are some of the things, but the buzzword here I want you to remember is bone marrow aspirate. They normally take it from the pelvis, will show greater than 20% blasts in the bone marrow, and blasts are just these really immature cells, whereas lymphomas, they're distinguished from lymphomas because they don't have those blast cells, like they're not the greater than 20% of bone marrow filled with them. You can do flow cytometry and immunohistochemistry to look at the different markers. So lymphoblasts have these 2 specific markers, and a lumbar puncture to see if there's any central nervous system infiltration. Obviously chemotherapy, there are some questions saying what are the common complications. So febrile neutropenia is one of the most common complications of chemotherapy. You don't really have to know the drugs, I don't believe. But you should probably know that there's an intrathecal, which just means like a lumbar puncture administration of methotrexate, and folic acid to protect the central nervous system infiltration. AML I won't cover, but essentially your buzzwords are your aura rods and the multiple aura rod cell as well. Same thing. And APML you treat with all trans-retinoic acid. So a otherwise well 4-year-old girl has petechia on her lips, recovering from a viral illness. So this is ITP, very common. Yeah, so it's called idiopathic thrombocytopenic purpura because they don't really know what causes it. They speculate it's like spleen autoantibodies against a specific group, but they don't actually know which autoantibodies cause it. So they've changed the name from immune to idiopathic. It's one of the common causes of thrombocytopenia. Second most common, is this, no, sorry, that's Kawasaki. Sorry. Okay. Acute, so it happens in children. So there's two different subtypes, acute and chronic. The one you have to remember is the acute one. So self-limiting due to viral infection, and symptoms just go away on their own, but sometimes children need supportive therapy. So again, you're looking for that recent viral infection, you're looking for that particular rash. Sometimes because you're getting all this bleeding because your platelets are getting attacked, so you can have intracranial hemorrhage, but it's very rare. Even if your platelets are less than 20, you still have a less than 1% chance of bleeding in the brain, obviously hemorrhagic stroke. And absence of malignant signs is really key because one of the differentials of obviously like petechiae and fatigue and stuff is your ALL. So these children won't have bone pain, they won't have hepatosplenomegaly or lymphadenopathy. They'll just have bleeding. And then when you do the FB here, they'll have isolated thrombocytopenia and platelets are usually less than 20. They can have leukocytosis maybe from a recent infection like plus minus. You can do coax to rule out other conditions because this is really a diagnosis of exclusion. And if you did a bone marrow biopsy because you were suspicious of ALL, you might find some megakaryocytes hyperproliferating to make up for the lack of platelets. Urinalysis to rule out HSP, you can consider that. No treatment if it's uncomplicated. Avoid obviously NSAIDs and aspirin. You don't want them to bleed more. Avoid contact sports. You can give them oral corticosteroids. I've seen this at MCH. So they give a low dose prednisolone for a short time, which just helps them increase their platelets. IVIG can be given if mucosal bleeding persists. And because spleen is the one chopping up the platelets, you can actually get rid of the spleen, and that's pretty curative, but then that has issues in itself, and you can activate a platelet transfusion protocol. 7-year-old boy with painful joints. This is a buzz. Couldn't be more buzz if it tried. So the HSP, which I found out today, is also called IgA vasculitis. It's fine. This is the most common vasculitis in Paeds, often preceded by a upper respiratory tract infection. You'll normally get this scenario of a 5-year-old boy with ERT symptoms. Now he's got abdominal pain and pruritic rash, normally in like the buttocks or high pressure areas. So that's kind of what the rash looks like here, and all in the ankles. Urinalysis is usually the only thing you require. If we're suspicious of ALL or ITP, you consider other things. Usually it takes 4 weeks, it goes away on its own. They also tend to have subcutaneous edema, so you can tell them to elevate their legs, use some simple analgesia, and just close follow-up. You can also do a renal biopsy if you wanted to confirm, and that will just show you the same thing as IgA nephropathy would show you. Past exam, a 3-year-old girl, weight loss, pallor, irritability, periorbital ecchymosis, abdominal mass, and bone pain. Bone marrow suppression only. So this is just one of the buzzwords. So neuroblastoma is we have 3 minutes. Okay, we got this. Neural crest cell tumor. So obviously these are the ectodermal neuronal cells that migrate, that form your sympathetic chain, as well as the cells within your adrenal gland. So the medulla cells are chromaffin cells, which are actually your nervous system's tissue. They secrete catecholamines, but they also release the breakdown enzymes, and that's why these tumors don't have the same thing as like a pheo would have, like chest pain and the racing heart and things like that. But what they do have is that they have these raccoon eyes, because the clinical features obviously vary on location, but it tends to be in the chromaffin cells in the abdomen. So you tend to have this large palpable midline mass because this is closer to the midline. You'll see later with nephroblastoma why I'm making this distinction. Can cause pain or constipation when there's a mass effect. If it happens in the thoracic region, you can have Horner syndrome. 60% have bone mets, and that's why you have these periorbital ecchymosis, because it's actually metastasized to those bones. And bone marrow mets means you have bone marrow suppression. And these are just some other little buzzwords that I have not seen come up yet, but it's there for you guys. Okay, 3-year-old boy, large unilateral mass, abdominal mass, and then recent onset hematuria. What if I told you there was Beckwith-Wiedemann syndrome? Would make it easier. Okay, so this is a nephroblastoma or Wilms tumor associated with the overgrowth disorder. Okay, I see you making noises, and hepatoblastoma and everything we didn't get to cover. And then also these are the other rashes, and this is the sheet where to find them. And then that's all. Thank you.